Thanks everybody for coming out. I really appreciate it. And I'm Lance Longmore. This talk, it's a first in a series. And I've told everybody here, if you have any thoughts of things you'd like to hear about, from someone like me, go ahead and write it down and, or tell me when you're walking around the neighborhood and we can put together, specific things. So the title is POTS and atrial fibrillation for the non-cardiologist. And, initially we were going to live stream it and have, both very interested patients. What you may know is people with POTS and atrial fibrillation, they know a lot about POTS and atrial fibrillation. And so, our marketing people, they're like, well, are we going to be able to pack this all together so that, both patients and providers can understand it? And I think actually a lot of my patients that have been struggling with these things, they'll understand a lot of these things. Now, hopefully we paint broadly and touch on some interesting issues. So just about me, for whatever reason, after I graduated from medical school in 2006, I just kept going to school, and my wife is very patient. And so we ended up doing 9 years of residency and fellowship training. The first 8 years were at the University of Missouri in Kansas City, and then a year at the University of Kansas. Then towards the end of my general cardiology training, in 2013, I came here to Pocatello as a general cardiologist. And on the way out the door, I kind of caught this bug for cardiac electrophysiology, for putting in pacemakers and doing ablations. And so I came here to Pocatello and I realized that there was no electrophysiology anywhere between Ogden, Billings, and Boise, and that there was a lot of need here. And so I went back to Kansas City for a year. Then I came out here and realized that there's a lot more to know. And so eventually I went, after a year or two, I went back to the University of Kansas and did another electrophysiology fellowship with further training in advanced ablation of complex arrhythmias, Watchman device implantation, and excimer laser and mechanical extraction of cardiac implantable leads. That's a lot of mouthfuls of things that I didn't even know about, a lot of them, when I was a board certified cardiologist. So, and it's interesting because you get at the end of all this training, and it's actually the longest training course in medicine, because to become a cardiac electrophysiologist, it's a minimum now of 8 years after medical school. And so you learn to do all these procedures, and then who gets the weekend dizzies? It's the electrophysiologist, and I've thought about it. It's like, yeah, we love to do procedures, but, you have to be able to balance, am I going to really be able to help you? And the thing that makes my day is when someone comes in and says, thank you for doing something, or thank you for not doing something. I had a patient a couple of weeks ago, and she couldn't even hardly stand up. And she's like, I've been to all these doctors, I've been to the ER, people give me fluid boluses, they say it's my diabetes, and sure, definitely, I agree, that was a big part of it. But I just checked orthostatics on her, and she can't even sit up without dropping her blood pressure by 20 points. And so, we're like, okay, orthostatic hypotension. We started treating it, and she came back a couple weeks later. And I mean, there's a lot of things you can say, oh, okay, do I need to monitor? Do I need a pacemaker? All these things. But there are very simple things that I think all of us do in our practices. And this is just kind of the area of overlap where, we have tools. And I think, the more specialization and training you have, a lot of times you just go to that. You're like, oh, it's this, that, the other. But, I like the idea that if I think simply about it, some of these other tools are things that can really make a difference if we know what it is that we're exactly taking care of. My practice includes diagnosis, medical management, and ablation of arrhythmias, and implantation of pacemakers and defibrillators. I'm experienced in Watchman implantation, which, if you're not familiar, these patients that you have that are falling, they should, yes, they should not be on full oral anticoagulation. But at the same time, if we don't do that, then there's a lot of stroke risk, in the same population generally. And so the Watchman procedure, it's a device that I can implant that reduces the stroke risk to an acceptable level while not having them on blood thinners. Because as you know, there are some people that you can't keep them from falling down ever, So also cardiac imaging, echo, TE, and of course, general cardiology. I like to take care of a broad range of patients. So I'm board certified in internal medicine, cardiovascular disease, which is general cardiology, nuclear cardiology, cardiac CT. I've read, I don't know how many thousand echocardiograms. About the Longmore Clinic, I've worked in the area for almost 9 years, and about a year and a half ago, I launched an independent clinic with a full staff and nurse practitioner. And the idea was that we would be able to send the patients wherever we wanted and take care of them the way that we thought they needed to be. And, with the idea being we can still have good relationships with hospitals and other people in the area, other groups in the area. And so the idea behind it is to bring advanced general and subspecialty cardiovascular care to the region. Also, we have a mission in medical research and medical education. And the idea is to increase patient access to both outpatient and hospital care, regardless of their location or ability to pay. And, in Idaho, that's a big, geography is a big barrier in a lot of ways. And so we have a lot of outreach, and we actually go to the patients and try to serve them in their area as much as possible. One of our missions is to advocate for our patients in wellness, as well as helping to navigate the healthcare system. And I think from the group that's here tonight, it just shows that, the focus on wellness is really, I think, what we all should be at least focusing on, not on sick care, but on healthcare. And, that includes underserved populations. Native Americans and other minority populations, rural populations, and the uninsured and self-pay patients. We try to work with all the hospitals and areas. We have clinics. I know all the cardiologists in Eastern Idaho, and there have been occasions when, patients like, well, who would you send your mom to? And, either someone here wasn't available or there was a specific thing that someone else did. And so I sent them to one of my colleagues in Idaho Falls, and just to make sure, or send them to Utah, whatever it is, to make sure people have the best care available in our area. Also, we have, we also are trying to increase during COVID, this idea of doing more telemedicine, telehealth. It kind of really expanded in medicine, and we're trying to increase that and keep that ball rolling, because the payers have picked up on that, and it's like, look, why is it that you have to necessarily be in my office all the time, for me to make some recommendations or whatever. And so we try to be accessible from a telemedicine standpoint. So what's a cardiac electrophysiologist? The first one I met was at the Cleveland Clinic in my third year of medical school, Mina Chung, and she writes, on a lot of the committees and the boards for Heart Rhythm Society. And I didn't know really what it was. I guess I was starting my fourth year, and it's like, wow, someone who has all this training stuff, that's awesome. But she was just really cool, and I was like, what is this specialty? And I think that's probably where it all started. So we're arrhythmia specialists. We do three things. We ablate, so we burn or freeze. We implant and we manage cardiac devices we install. And most importantly, we take care of patients, or we doctor. And that's what all of us in this room do. We take care of patients. And that includes those with syncope and near syncope, the weak and dizzies, near syncope, also known as pre-syncope. So Hippocrates, was he the first electrophysiologist? He famously said, those who suffer from frequent and strong faints without any manifest cause die suddenly. And you've called me before and been like, I don't know what's going on here, but something's not right, and one of those patients came back in, and your clinic correctly recognized she wasn't well. She had a UTI, and she looks great today. So, it takes a village, right? So intracardiac cardiography, very interesting, right? And so you kind of look at it and you're like, whoa, they stuck these catheters in this poor horse in 1894? 1864. It's really small. But anyway, you think this kind of looks ridiculous, but this is what I do to human beings. To do an EP study, we put catheters in, not in this way. Animals are amazing, right, to go through this. But, we use veins and arteries. We get up inside the heart, and we actually do, intracardiac EGMs. Here's another one. It's kind of small there, but it's Mercurial in 1580. He published a paper entitled Ubi pulsus sit rares semper expectanda es syncope, where pulses far apart always expect syncope, which is kind of interesting that 600 years ago he identified that. So in 1958, Elmquist and Senning, of the famous Senning procedure, an implantable pacemaker for the heart. So went from 1500s to 1958. Here's the first documentation of ventricular fibrillation in 1894, which is interesting. And then these are early ECGs where you get hooked up and you put your foot in the bucket and they do that. So arrhythmia in medicine, 18th century and prior, recognition, 19th century EKGs, 20th century pacing and management with medications, and 21st century interventional electrophysiology, which doesn't negate anything else that we do that helps people. It's just we have more tools now. So common denominator of syncope, which is this loss of consciousness suddenly with loss of postural tone. The mechanism is hypoperfusion of the cerebral cortex and reticular activating system. So in other words, there are neurological reasons that there can be loss of consciousness, and there can be cardiovascular reasons. So, just briefly, syncope versus seizures, the prodrome, and this is where you're getting the story from the patient. They're telling you a lot of things. So, with seizures, they may have an aura or an odd smell, whereas with, syncope, non-seizure type of loss of consciousness, cold sweats, warmth, flushing, lightheadedness, blurred vision, and then with seizures, post-event, all the different things like the post-ictal state and things like that. Syncope, and a lot of my arrhythmia patients, they'll lose consciousness and they'll come back. And people who witness it, it's not this kind of like groggy thing. It's like, no, she was back, and she was with us. So what is it that turns out the lights? So as far as cardiac syncope, so you have neuromuscular syncope, which is reflex syncope, vasovagal syncope, carotid sensitivity type of a syncope, and then situational things, GI, GU, respiratory, orthostatic syncope, and then this is something that's kind of, and this is where we get to POTS, right? So people think orthostatic. When I say the patient is orthostatic, anyone just want to chime in, and what are you thinking when I say the word they are quote orthostatic? Yeah, blood pressure. Like, in other words, I think we abbreviate that to orthostatic hypotension, right? So in other words, our older patients who don't drink enough, and we're saying you need to drink more water and blah, 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 blah. And, they're like, I do. And, the family's like badgering them and you feel sorry for them. So it's like this orthostatic hypotension. And that's, one thing. But there are other things that in the orthostatic position, the blood pressure doesn't drop. And then they pass out. So just kind of in your mind, rewire that, because then we start talking about, in this orthostatic column, autonomic failure. And so, is it orthostatic hypotension or some other type of autonomic failure? There's arrhythmia, which is 10%, AV block, they need a pacemaker, VT, the aortic stenosis, HOCM, PE, and on and on. Less common things you don't see. Now, all this is saying it's busy. This is basically saying if people don't pass out, they're on this top black line right there as far as survival, right? So if they have vasovagal, and this is interesting because, if you have like a 20-year-old kid with zero risk factors for anything, and he's in a hot dog eating contest, and he's like eats hot dogs and throws up and passes out, or a needle or something, you could almost by just history know that it's vasovagal syncope or something like that. And you can see survival with that is just the same as people who don't have any syncope. Now, this unknown cause here is in the middle. And, if someone just passes out once in their life, at least a 50% chance or so that we're not going to find out what it was. Now, neurological causes here, right? But then down here, these cardiac causes. And so that's kind of the scary thing of, what do I rule out and who do I send to the cardiologist? And, that's something different. But, once you get done with that, then we look at the other things. So tilt table testing. And, when I first was, when I was in training, I'm like, why can you just put someone upright and they pass out? It just didn't make any sense to me. But, the heart and the neurological system, they interact in such a way that they're telling each other very rapidly how to adjust for different postural situations. And so if you think they might have reflex syncope, but it's not confirmed, you can do a tilt table test. It can discriminate convulsive syncope from epilepsy. For example, are they dropping their pressures and seizing or having convulsions, or do they have epilepsy? And I had one patient, again, another story. He was having seizures, but it was in response to basically severe vasovagal responses. And I put a loop recorder in him. I documented it when he went off a jump up at Targhee, and he tucked and he went off this jump. And when he landed, his heart rate dropped below 20 for like a minute. And he had a seizure, and his girlfriend watched it. And that's one of those rare things where it's like you have vasovagal syncope, which we really try not to put pacemakers in. Honestly, it's like it doesn't help most people. But he was seeing the neurologist, but we had all the data, and he was a young guy, put a pacemaker in, and I'm still seeing him a couple of years later. He hasn't had a seizure since. He doesn't have epilepsy. It's just he was hypoperfusing his brain, right? So, and then, for the chiropractors and physical therapy here, distinguishing syncope from falls, right? This is a huge thing. And when I'm going through it with the patient, I'm almost to the point where I should probably just send them to one of you guys to kind of document, what is the actual risk of them falling, or are they having something else? Because we do monitors and other things, but sometimes it takes some just ambulation and other types of testings. Now, occasionally I find someone who they think they're blacking out. I have a patient I'm thinking of who we put a loop recorder in. Her episodes were convincing, and finally neurology was like, well, you've passed out how many times? And it's like 3 times a week, and you've never hurt yourself, And she actually came to me, and she said, yeah. I said, well, what did he tell you to do? She said, he told me I need to see a psychiatrist. And I said, what do you think about that? She said, I think thinking about that, that's right. But we documented everything. I had a loop recorder in. There were some funny little things, but nothing that should make her pass out, And so it's interesting how that also helps tease out some of these psych issues that people perceive, and so we could also use it to discriminate neuromotor syncope from delayed orthostatic hypotension. So introducing that phrase, I think I said NMS. I think I said that wrong before. It's neuromotor syncope. I must have been nervous. And again, there's no value in evaluating the efficacy of a drug by doing a tilt table test. I'm going to skip over that. So now to one of the topics that I promised to talk about. So postural orthostatic tachycardia syndrome. And what I'm learning is it's an autonomic dysfunction that affects the heart, but it also, the GI system, and obviously there are neurological things. I have some patients who have primary diagnosis of autonomic dysfunction that was diagnosed first before the actual POTS that makes them pass out. So all these symptoms that can be a lot of different things: dizziness and lightheadedness, shaking and sweating, weakness and fatigue, shortness of breath, chest pain, fainting, palpitations, headache, poor sleep. Now, if I hadn't told you this was a POTS talk, what would you have said? There's like 50 things that could be this, right? And so I think this is a good kind of little graphic here where the blood volume when they're standing. And this is kind of an interesting concept because, again, going back to this orthostatic hypotension, by definition, POTS is not orthostatic hypotension. And so I see cardiologists write this all the time, no offense if you're watching, but they'll say, POTS and orthostatic hypotension. It's like, well, it's either one or the other. Now, I do have an interesting thing. I have a couple patients who, I know they have POTS, but if they're dry, I think sometimes they do have orthostatic hypotension. But if they're tanked up, if you give them IVs or, get them tanked up and they're standing up, they meet criteria by increasing their heart rate and their blood pressure does not drop, but they pass out. That's POTS, or feel lightheaded or symptomatic. It doesn't have to be full syncope. But I think this is a great graphic because where do we take blood pressures? We take blood pressures on the arms. The arms are next to the heart. So, for centuries, we've assumed that that's kind of, it demonstrates what the blood pressure is, and we assume it's everywhere. But I do, ankle brachial indexes, for example, to see the difference in, blood pressures in the legs and arms to see if they have vascular disease. But this graphic shows you right there, if the blood volume drops out of the head, you may have normal blood pressure here, but that graphic I showed you before, the syncope of hypoperfusion is going on in the brain. And so I've been thinking about it, and I've been trying to think of different ways to explain this to patients. If I had some kind of a device I could put up in your brain to check your blood pressure, it would show that it's dropping because you're symptomatic. And so the physiologic response, right, and we think of hypotension, that will get tachycardic to try to make up for that. And that is, one of the deficits of orthostatic hypotension is if their heart rate can't get up to increase the cardiac output, then they're going to pass out, they're going to faint. And some of these older people, they may need a pacemaker to help them to get that heart rate up because they can't do it anymore. Their system's not working that way. And the same way, with POTS, the body is physiologically trying to get the volume to the brain. The brain's a very greedy organ, and it will do anything to try to protect itself. And, it's a good thing too, because we need our brains, right? And so this is a good graphic of what's going on there. So here's the graphic, or this is the diagnostic criteria for POTS. And so when you see the word orthostatic from now on, I want you to think of something that happens in the orthostatic position, okay? So there's orthostatic intolerance, but then you need to know, is there autonomic weakness that goes along with that? So sometimes you can get kind of a mixed picture. But in the orthostatic position, just kind of teasing out that first, that's the thing to realize. Is this orthostatic? Like I'll have patients come and they'll be like, I'm passing out. Someone thinks I have POTS. I was like, is it always when you're standing? I'm like, no, sometimes I lay down and I feel lightheaded. And it's like, well, okay, maybe you have POTS, but maybe you have vertigo too, right? And so that's the hard part. And I've had patients who've had the $1 million workup in multiple states. They'll go all over the place and, what I'm thinking of, and she ended up in Boise, and someone out there wanted her to see a cardiologist out there. And she came back to me. I said, well, what did the cardiologist in Boise say? And she didn't have POTS, though. And that's the thing. She said, well, she told me I thought I had POTS, but that you're an electrophysiologist and you know more about it than she does. So she sent me back to you. But in the end, I ended up sending her for, I called the ENT. I was like, oh my gosh. I was like, I know nothing about Meniere's disease, but she has like ears ringing and vertigo and all this stuff. And I called, one of my ENT friends, and I'm like, hey, this patient with this and that, and we're wondering about her thyroid, and we're wondering about POTS. I said, she was telling me today that, this particular symptom goes along with when she turns her head. She's had all this earring. I said, I don't know anything about Meniere's, but what do you think? He's like, wow. He's like, yeah, And so that's when we started going down this other road of, okay, let's have someone do a very good evaluation. I used to think, I'm just this year learning that not everybody does Dix-Hallpike maneuvers the same, I guess, because I'll have people come back who are like, well, they did something, or they'll give them a handout and tell them to go try it at home, or they'll YouTube video, go look up, does this happen? I mean, yeah. And so, I had a local physical therapist tell me that, it turned out in the North California and Nevada, nobody wanted to do, a very complete, evaluation of people who are weak and dizzy. And so, this goes along with orthostatic, being upright versus turning the head, or, my heart pounds and then I'm lightheaded, which, say they're having VT. That's something that could happen while you're lying in bed and you have VT, or you have some other kind of neurological symptom. So symptoms with POTS worsen with standing, they improve with recumbence, and it needs to be, it needs to sustain, for more than at least 6 months. And some of these types of things, and I don't understand this completely, but deconditioning, autonomic deconditioning, and we'll have someone in a hospital bed for a week or two, or they're sick. I think when I had COVID, I think I ended up with, whether it was the COVID or just not being able to stand up, after 2 or 3 weeks, I was like, dizzy and lightheaded. But there is a good amount of deconditioning. And so, the university here, every now and then, every few years, probably every other year or so, I'll have one of the trainers bring in a very tall basketball player that, can't stand up, and they haven't been training over the summer. And so the first thing I say is, get in shape, start gradually increasing your tolerance, and then I don't see them again, right? And so people will come in with POTS symptoms, right? And even before I get to the tilt table test or whatever else, it's kind of like, well, try a little of this. But like it says here, it needs to be persistent. It's not just something that came with an acute illness or deconditioning. So, and again, I think this is the thing that just gets missed across the board, because we think of orthostatic hypotension. By definition, to diagnose POTS, you have to have the absence of orthostatic hypotension, which is a greater or equal to 20 millimeter drop in the systolic blood pressure. And, you lie the patient down, and then you take their blood pressure, you sit them up, and properly you wait several minutes, and sometimes we speed it up a little bit. But some of my patients, you sit them up, you take their blood pressure, and it drops. And again, I have all these board certifications, and the thing that has lately, dealing with these kind of patients and looking at the different presentations, I had a young patient that when she would sit up, her blood pressure would drop, type 1 diabetic, and then I look back at it, and really her heart rate, and so she does have orthostatic hypotension, but I think, looking at her monitors, her EKG was slow, and she had bradycardia, and she really has what we call chronotropic incompetence, where physiologically, and it could be neuropathy related to the diabetes, she's not able to get her blood pressure up with increasing her heart rate. And so I'm looking at some of those patients now that maybe they're not as responsive to midodrine, or maybe they're not as responsive to upright training or hydration, and maybe they actually need a pacemaker. And so, again, absence of other overt causes of orthostatic symptoms or tachycardia, right? So, all right, so that's this one. And so these are some of the common medicines, and it kind of, it's kind of painful to me, and this is a lot in cardiology. They'll have a young person whose resting blood pressure is like 98/60, they're healthy otherwise, and they have, maybe they do have POTS, and then they'll try to start them on a beta blocker, and then they're like, oh, I'm really dizzy now, because then they do have hypotension and everything else, and so it's kind of painful. We do, if people tolerate it, if they have blood pressure to spare, it's wonderful because, metoprolol is cheap, people can be on it for life, and if they tolerate it and don't have symptoms. Some people, it's true, and it's usually thinner, younger people, even a very small dose of metoprolol, they just don't tolerate it. But sometimes that's a good fix. I do have a few patients where they had some blood pressure to spare. We diagnose POTS, we get them on a beta blocker, and just tell them to hydrate, and they've done well. But again, you have common side effects: headache, irritability, rash, ankle swelling. So ivabradine, it's really a game changer for POTS, because if we diagnose POTS, if they could get ivabradine covered, I can't think of a patient who didn't say ivabradine made life livable for them with POTS. The problem is the only class 1 indication for ivabradine and the FDA label is for congestive heart failure patients that you can't get their heart rate down to 80. So why is ivabradine such a game changer? So it acts on the funny channel in the SA node, which directly controls the heart rate. So we have AV nodal blockers, right? Your calcium channel blockers, beta blockers. But the problem is they also lower the blood pressure. This is really the only medicine we have as far as directly affecting the SA node to kind of blunt that tachycardic response. So what you end up with is, without ivabradine, you have increased heart rate, you have increased norepinephrine circulating in your body, you feel crummy, and then after 1 month of intervention with ivabradine, you have patients, that person walking around with a lower heart rate, lower norepinephrine, and a better quality of life. And it's interesting, it says after a month. I usually see it after less than a week. The problem is it's rarely covered, and people, it ends up being like $5 or $10 a day or something like that. And so I don't know. I try to tamp down my irritation with some of the economics, but it does work. And so compared to placebo, it significantly improved physical functioning and social functioning. And with these types of things, studies in POTS, this gives us some more ammo to be like, this should be covered, this should be done, things should be paid for. And I think we've gone over this. POTS is a systemic disease of the autonomic nervous system. It shares clinical characteristics with chronic fatigue syndrome. I see a lot of patients, and they have like chronic fatigue, they have fibromyalgia, they have, like POTS, and then they go into their primary care and they're like, gosh, let's start you on an antidepressant. And I'm like, well, I'm not really depressed, or, whatever it is. And then they go to the cardiologist, and the cardiologist says, I don't know, maybe it's POTS. But, you have all these different symptoms, lightheadedness, palpitations, tremors, blurred vision, and, exercise intolerance. It's kind of this vicious cycle and fatigue where you can't exercise, so everything gets worse, So yeah, symptoms in the morning, more pronounced, female prevalence, and I don't know if this is a biased statistic, greater than 75%. I don't know if it's that because people were looking for it in females, or, and we all know how that is. And so this shows you diagnosis of POTS. So if their heart rate pops up, and you can see heart rate up here on the top, in a POTS patient within about 20 seconds, and it could be longer than that, but and a lot of times people will give you this story of, for example, someone comes in and they say, every time I stand up, I get lightheaded. What do you think of? Orthostatic hypotension, right? Then you have this other story where they're like, I've been standing at the sink for like 3 to 5 minutes, and all of a sudden I can't stand up anymore. Then I'm like, maybe that's POTS. So there are, different time frames for this, but it has to be fairly early to call it POTS. And you can see the control here, how the heart rate just kind of gradually increases and so forth. So that's a part of the history where, if there's some separation from just standing up, like orthostatic hypotension, then, I'm thinking more about POTS. Go ahead.
So some of these patients you're kind of describing right there, you go through the whole workup.
So Chiari malformation, that's a really good, I haven't accessed that part of my brain for a long time. You can have pressure increases, vascular pressure increases in a lot of areas of the body. For example, in the carotids, there's baroreceptors there, right? And I know there have been some people, for example, venous congestion that mimics MS, multiple sclerosis, for example, things like that. I think we do have a lot of work to do to kind of tie this stuff together in how other types of things affect the neural inputs to the heart, So that's good, though. I'm going to start putting Chiari malformation on my differential. It's kind of funny you say this because if I'm going down the orthostatic hypotension road, they may have a family member there to kind of rat them out as far as drinking water or whatever. But I'll say, what color's your urine, in the afternoon or evening, And a lot of people, I know it's dark and, whatever. Some people, though, they're like, it's clear and I drink a lot of water. That's where I'm kind of like, that's where I need to stop shaming them for not drinking enough water and think of maybe I'm needing to do something to help with their orthostatic hypotension. Salt tablets, thermotabs, you can get them over the counter. That's a good trial. Interestingly, volume expansion, right, for either POTS or orthostatic hypotension. At first, it almost doesn't matter if volume expansion works, right? And then you have to see, is this something that they can live with over time? So here's treatment for POTS, Heart Rhythm Society, which are the electrophysiologists. So I have this pyramid showing, level of evidence and recommendation. And so the yellow at the top, those are class 2A indications. And so class 1 indications are things we should do. It's like you should do it. The evidence supports it. There's benefit. And what it means here is if you're not seeing green at the top, there's probably not a ton of studies on it, randomized controlled trials or things that give us clear guidance on what to do. So 2A, the light orange at the top are things that we should probably do. The darker orange are things that maybe we don't do, but we can do if we feel like it's appropriate. And then the red stuff at the bottom is like, no, don't do it. Class 3 indication. And so, so the top few things is, do a good workup for POTS. Can you give them saline, for example? Yeah, give them saline. Give them a trial. And you can do that as an outpatient. You don't have to put an IV in them. Volume expand them, right? There are a lot of things you can do. And I love this here. I wish we could see the slides better. I'm going to get a bigger screen or something. Maybe if I next time scoot it back. But this one right here, you probably can't read it. But it says patients with POTS might be maybe best managed with a multidisciplinary approach, which is why I love that we have chiropractors and physical therapy here, because it doesn't matter which one of us notices what's going on. It's who's there, and then really getting their sodium up. 10 to 12 grams of sodium daily. Have you ever heard of a cardiologist telling people to get their sodium up to 10? I've never done that much, but and then could be reasonable to treat them with fludrocortisone or pertustigmine. We try to avoid some of those things. And somewhere in here, ivabradine. I think ivabradine is a 2A indication. It might be a 2B, but I didn't see it on there. Okay, so here's syncope. All right, just kind of quickly, as far as monitoring, you're thinking about people who are passing out, and it's not necessarily part of the workup for POTS, but they may have other things where they end up wearing monitors, we're not catching anything. Any monitoring that we do, we should be thinking about if we're going to catch the symptom, right? And so this is an implantable loop recorder. It just goes under the skin. We do these in the office, where you just pinch it, make an incision. And it's got a battery that lasts for 3 years. And that's the nice thing, because if and when they pass out again, then we can say, was it, did they have an arrhythmia? Did they have a pause? Something else? A lot of different things. So this is just indications for tilt table testing. And then this neurological testing, I think you have to go right now to the University of Utah to get a full autonomic evaluation. But I think it's a need in the area, and that's something I'm moving into is doing some of these things. We're doing tilt table tests in our office, and we have the monitoring and things available. But I think we need to expand that to do full autonomic testing. How much longer do you guys want me to talk? Do you want me to be done? Do you want to hear about afib, or do you want to hear about afib? Will end in fire, some say in ice. From what I've tasted of desire, I hold with those who favor fire. But if it had to perish twice, I think I know enough of hate to say that for destruction, ice is also great. You're probably thinking, what in the world is this guy talking about? And what does it do? What does it have to do with cardiology? So what is an ablation? An ablation is destruction of tissue to interrupt problematic electrical pathways. And so we can do it with radiofrequency energy, which is burning. We use radiofrequency ablation to burn. And now we use cryoablation, which is freezing. So that's what the point of the poem was, is, you can also freeze to interrupt these pathways. So this is kind of what it looks like when we do an ablation. And when we ablate, we now have irrigated touch-sensitive catheters, which, if not improving safety, they do improve the ability to burn, deeper and more effectively. We have a lot of parameters we use to make sure we're safe when we do it, or at least give us the best chance to be safe. This is a cryo balloon shown going into a pulmonary vein. This is an EP study where they've got some catheters coming up from the groin. There's one coming down from the internal jugular. And so what I tell patients is we put up the catheters, we try to get it started, and then we play a game of Marco Polo where we see how close we can get. And we do mapping, we get the old-fashioned EGMs, and then we also get 3D mapping and electroanatomic mapping and activation mapping. We can do pace mapping and a lot of different things with the catheters. So burning, there's this fast, nasty rhythm, and the pretty pictures on the bottom. I think this is what captivated me when I first saw this, and I was like, wow, that's cool. Look at the pretty pictures, but it represents a lot of physiology going on there. And this is just kind of going through a few things that we do. This is a pacemaker, dual chamber, showing the device, and then a couple of leads going down into the heart. And I'm kind of just showing a few things. So you think of AFib, and so we give people medicines to either keep them in rhythm or control the rate, and then they have tachybrady syndrome. And do I put in a pacemaker? Well, if I put in a pacemaker, maybe I'm going to do an AV node ablation so that I can take away the medicines, right? But putting in a pacemaker, for a lot of different reasons, there are a lot of complications you can have. Hematoma, infection, lead dislodgement, pneumothorax, Twiddler syndrome, pacemaker malfunction. So, these are all things I have to take into mind if I'm offering someone a pacemaker. And they taught me in my training programs, they're like, you just have to remember these leads that you're putting in, if they're in there long enough, they're going to fail. And so being able to manage those things. So the reason I'm telling you that, because this is one of the newer technologies over the last few years. It's the micro leadless pacemaker. So if a patient has an indication for single chamber pacing, for permanent atrial fibrillation, where they don't need 2 leads, or very rare pacing, some younger people with symptomatic bradycardia at different times might get that. But you put it in and you release it, and it's there, and there's no leads, and there's nothing to get infected up here. So it's really cool. And now I need to update my slide set, but now we're getting it so you can put it there, and it'll sense the atrium. And then the next step is to put these in different places inside the heart that communicate, and you never have to have the leads, which in the long term can cause a lot of complications. So we're moving forward. So this is a trial that a lot of times doctors will use to say, oh, it doesn't matter if they're in rhythm or not. And that was, they did rate control versus rhythm control. but the end point was all-cause mortality. But there was no survival advantage with cardioversions and antiarrhythmic drugs. And so a lot of people hang their hat on that as far as just controlling the rate with just getting them in rhythm, and so that they're not having AFib or not having as much AFib. And again, rate does not equal rhythm control for all. And what I've noticed is my patients who go, bedroom to kitchen, kitchen to chair, chair to bathroom, they don't really notice it, but anybody, and typically they're under age 80, if they're active and things like that, they'll tell me, and I have a slide on this, but they'll tell me they feel things. And so, again, this is just showing people with coronary disease, and you can see the survival curve. So this is death up here. So people with coronary disease and who were staying in AFib, they had more mortality, and those who didn't were lower. And some of this may be mediated by bleeding and falls and stuff like that. So these are the types of things I'm talking about because, my goal for my patients is to increase their quality of life. So how do you feel now compared to before you were diagnosed with AFib? And these are things I hear. I've lost my top gear. I'm a little more short of breath. How about this one? Do you ever hear this? I'm not as good now, but I'm getting older. And I'll say, so when did this start? Oh, 2 years ago? And I'm like, okay, so you're 76, yeah. And so you were 74, yeah. So 76 is that much older? And 74, what were you doing? Oh, I was, hunting and doing everything I want to. Well, something happened, And so then we have to drill in, is it the AFib or is it something else, right? And so there's a lot of things, anemia, sleep apnea, whatever else. What else is going on? Don't use age as an excuse for real disease that may be treatable. Consider some of your patients may have excellent functional capacity into their 90s. Why do others not have that functional capacity? It's not just their age. There's joint disease, lung disease, cardiac valvular disease, medication side effects, and AFib, right? So, what are you trying to achieve? And I say this several times a day. My goal is that my patients are being there for the activities that enrich life with as few medicines, as few procedures, and as few hospitalizations as possible. Because they need to be doing stuff. They need to be minimizing what we're doing as far as medicines, procedures, and hospitalizations. Lots of studies on age, the effect of age on functional and mortality outcomes after acute myocardial infarction. This was done by colleagues of mine at St. Luke's Hospital in Kansas City. And they found that after a heart attack, age was not associated with functional decline in unadjusted or multivariable models. But age was strongly associated with one-year mortality, but not with the combined endpoint of death and quality of life. So in other words, yeah, older people do die more often. We used to think that smoking was good after a heart attack because they didn't die as much. Well, it's because they had their heart attack 10 years earlier. And so youth is on your side in those cases. But quality of life is something that we can preserve for people, well into their 90s a lot of times. So these super agers, and I've had people, I'll do an AFib ablation, and they'll come back and they'll be like, wow, they love me. And I'm like, it's so happy, those days when you can really tell that you helped somebody without amiodarone. I mean, that's the other thing. It's like, there's all these medicines and yeah, you Google it, amiodarone is nuclear rocket fuel. I'd love to get as many people off amiodarone as possible. It's overprescribed, it really is, And we kind of give into it in a lot of ways, but with what I do, I like it to be a short-term fix so that we can get to the next thing, All right. So let's see here. We don't have much time. So some things to remember. AFib begets AFib, and its corollary arrhythmia begets arrhythmia. And so the more you have, the more you're going to have. Right atrial flutter and AFib go together. Solved study, patients with LV dysfunction, AFib was significantly associated with increased mortality with AFib versus sinus rhythm. Is sinus rhythm better than AFib? Yes, but that's not the question. The question is the juice worth the squeeze? So in other words, am I willing to go do procedures and give them medicines and all this kind of stuff for the benefit of sinus rhythm? Okay, and this is showing you antiarrhythmic drugs. And as you're, seeing patients and they're like on sotalol or amiodarone or whatever, and people are thinking, oh gosh, we don't want to subject them to a procedure, but the medicines aren't as good at getting them into AFib as the procedures, and there's annual risk. I get an EKG every 6 months on my patients on antiarrhythmic medications. That's the long and short of that one. And then the question is, should we just send everybody for AFib ablation when we find AFib? That's still, it's getting safer, it's getting more effective. And in the end, that's really all we should be looking at because, for an elective procedure, is that benefit worth it? But with the safety improving, there's more people that you look at it and you're like, yeah, I'm just going to do this. Maybe they don't want to be on, antiarrhythmics or something like that. That's got to be taken into consideration. It used to be people would think they have to fail all these antiarrhythmics and then you take them to ablation. But that's the beauty of what I do is I can look at it different ways, talk to the patients about their values. Most of my patients would rather have, a procedure and rather than go on and on with it, particularly if they're younger. If you're 45 and you're looking at 80 years of flecainide, I don't know how long people are going to live, but even if you're looking at 40 years or 50 years of flecainide, it's not good. And again, we're looking at quality of life. That's the main thing we do with catheter ablation. Here's one. The SF36 and AFEQT are any of you familiar with quality of life metrics? We should be, because in the end, if we're not making life better for people, or if they're not improving their quality of life, and we got really good, I think, in the 70s and 80s and 90s with keeping people alive. You told me a story about keeping people alive, right? And in the end, it's like, why, right? And so I'm glad that the palliative care movement and some of this kind of ethical consideration has come into consideration. And the holy grail is still mortality. We want people to live long, but we want them to also live well, quality of life. And so I did a 1-year cardiovascular outcomes research fellowship with John Spurtis, and it was programmed into my brain that health-related quality of life predicts almost everything else. And so if you're talking to your patients, they're not feeling well, they don't feel like life's worth living, they're not going to do well. If they feel like things are going well, and this is the SF36, it has physical and mental domains and things that go into it. So the conclusion was ablation demonstrated in this particular study significantly improved quality of life compared with anti-arrhythmia drug therapy. Amiodarone, again, significant tenure risk, liver, thyroid, lung, eye. On a year-to-year basis, if we're checking things every 6 months and all that kind of stuff, we can manage that risk. But again, it's better to be without it in most patients if we can do that. Digoxin, I see way too much digoxin. Do you see a lot of digoxin? Overprescribed for that purpose. And again, I think this is kind of the take home. Like when you're thinking in the back of your mind, I'm diagnosing helping diagnose a Chiari or whatever it is or you're calling me with tachycardia. What are we looking for in AFib? We're trying to minimize patient symptoms, dig deep into the history. They may be sugarcoating it. And, I'm fat or I'm old, and those things. And prevention of AFib-related heart failure exacerbations, stroke prevention. Tons of strokes could be prevented if we find the AFib, and some recurrence with rhythm control is acceptable. And, a lot of the studies for AFib ablation, they want perfection. They're like, you're never going to have AFib again. Well, if I take someone who's in AFib all of the time or most of the time, and I can reduce their burden to 5%, they can live life. And maybe they can be on a beta blocker instead of amiodarone, right? And so that's what I tell patients, depending on what it is. And most patients, I can truthfully tell them, there's a 95+% chance I can get you off amiodarone, which is big, right? So anyway, there may need to be repeat ablations. We don't like to do more than 2 for AFib. But there we go. I didn't touch on like sleep apnea, hypertension control, but these are some take-home messages. Atrial fibrillation is a progressive disease, and it's best treated or eliminated early in its course. So some people say, oh, I had AFib, I was in the ER or whatever. It's like, no, you didn't have AFib, you didn't have AFib. It isn't that you had AFib, you have AFib, right? There's only one exception to that, and that's immediately post-cardiac surgery. If they've never had AFib before and they do, that may be something that we say, okay, let's do amnio for a couple months and then take away the amnio and anticoagulation. But if the AFib comes back, then we need to treat it as this progressive disease. Physiologic factors lead to reduced cardiac output, worsened quality of life, and increased risk for congestive heart failure. Truly asymptomatic rate-controlled AFib is uncommon. I should add in active patients. In less active patients, they can be asymptomatic. And again, better tolerated in the elderly. Catheter ablation likely gives a better chance. I mean, all this, the wealth of breadth of data shows that catheter ablation gives a better chance of success with rhythm control rather than antiarrhythmic drugs. Ablation is indicated in most patients that aren't, elderly. My cutoff is usually about age 80. I've done AFib ablation. I did 2 on someone. She's almost 83 and she loves me, and it was really hard. And I was like, oh my gosh, should I do this? But she was so active and, wanted to be active that we did it. And it, she's done great, and I'm glad that we did. And again, it can be considered as first-line therapy. It depends on the patient's values and what they want to do. So, which one of these patients would an electrophysiologist like myself see? Any atrial fibrillation patient, medical or ablation management. So that's the thing about it. I have all the tools. I can go, I went to osteopathic medical school. I don't do manipulation and things like that. But if that's what someone needs, it wouldn't be me that did it. But then they need manipulation. If they need, some other kind of physical therapy or whatever it is they need, if they need a beta blocker and whatever, I can evaluate any of these patients and say, okay, here's what I have to offer. And then I bounce them back to their primary care. They're either going to think about it, or I think most primary care, they'll say, do what you're going to do, and then have them come back. And I say, yes, no, you don't have to see me forever. I check in on you, but you need the others who love you so much. And in these older patients that we're not going to do, left atrial ablation, AV node ablation, which is the ultimate rate control, because then I control it with a pacemaker, and biventricular pacing for AFib with refractory heart failure. So people with low ejection fraction, and there are options beyond the bigger, AFib ablation. So thanks for your patience. Thanks for coming. Any questions? I know I breezed through some of that. Sorry for putting too many slides in. Anybody just did I not touch on something, or did I put you to sleep? Or